I'm Raj Dave at C3 2018 in Orlando, Florida, and it's a great privilege to have Dr. Bryan Kluck, one of the course co-chairmen of C3, immediately after a symposium for antiplatelet therapy for acute ischemic coronary syndrome. And it was an absolutely fantastic symposium. I really thought that the cadence of the speakers were incredible and the topics were really timely. And there was a tremendous discussion about all the potential nuances related to a newer generation of antiplatelet therapy, duration, starting, selection. Many of these issues were discussed today. So Bryan, give us a brief overview of what was really discussed in terms of the essence of the guidelines, that how we view antiplatelet therapy in context of the guidelines.
Raj, I think that is a good place to start. This topic has been something that we've had a seminar on each and every C3 for probably the last 7 years. And it's astonishing that even if we put it at the end of the day after a long day, people fill in the seats and they are in rapt attention to this topic because of the nuances that you really talk about. This year, the guidelines have changed. Christian Ruff did a great job of summarizing the fact that the US guidelines have really now sort of evolved in the direction that the European guidelines have probably gone several years prior, to include newer generation dual antiplatelet therapy using newer generation P2Y12 drugs in preference, particularly in cases of ACS where they seem to have an advantage. And giving those drugs the nod in those circumstances really now is supported by the guidelines both in the US as well as in Europe. And that was something that was not only nuanced, but something that in practice we've been doing, but nice to see that the guidelines have really caught up.
So, one thing that became very clear today after listening to Christian Ruff and all the rest of the discussion, that a patient comes in with a STEMI based on the results of the Plato, ticagrelor really is the preferred agent.
I think that's true. I think at this point there are reasons to use third generation drugs, and ticagrelor has an advantage of cardiovascular mortality reduction and really seems to have at least a favorable response in terms of bleeding to some degree. And so now that drug, given the nod to be at least contemplated as a first-line therapy, really does change the game a little bit in terms of the guidelines.
So I heard your very interesting talk about genetic testing and platelet function testing, and it is pretty clear that there are definitely a group of patients that come to us that has some form of clopidogrel unresponsiveness to a certain degree. Absolutely. And if you are coming in with a STEMI or a non-STEMI, there is really no way to test these things.
That's true.
So, those patients really should be given a non-P2Y12 drug, such as ticagrelor, which has a different mechanism of action. And I think that in a certain way is supported by the guidelines is what I was gathering from the totality of the discussion.
I agree, and I think that's exactly right. I think there are, the question early on was whether or not to test everybody. And the fact is, whether it be by platelet aggregation type testing in the form of light transmission aggregometry or its point of care equivalent, or whether it's in terms of genetic testing, in both cases there are circumstances where you might want to do it. But do you want to do it, is there a need for doing that if indeed the pendulum is swinging to use third generation P2Y12 or P2Y12 equivalent drugs? No, that's not a reason that you might want to use it. If you think there might be an economic reason or an absorption reason, or in a case of stent thrombosis, absolutely. I think the data is becoming more clear that it's no longer binary. Don't test or test based on the gravitas data. I think now there are other things. There's also an interesting concept of de-escalation. So with tropical ACS, potentially what you can do is you can start with a more potent drug, in this case prasugrel, and you can then test 2 weeks down the line or 1 week down the line, and you can see if at that point the patients are no longer having high on treatment platelet reactivity, you can theoretically try to de-escalate them under guidance. So there are now newer ways to do this. And what's more, there are actually more point-of-care genetic testing approaches which may allow this to be feasible in the acute setting. But to your point, why would you do it if you're not actually going to put person on a drug that has such a wide variation in absorption the way clopidogrel does?
Yeah, I think that, as you know, I use a lot of genetic testing in my personal practice. And the reason why I mainly use it is because there are sometimes cost implications of patient not being able to afford the latest antiplatelet therapy. And I may, for economic reason, may want to switch patient back to clopidogrel. And then I think it's very fair to look for CYP2C19 mutation to make sure that patient is going to be clopidogrel sensitive rather than clopidogrel resistant in some fashion, and that's where the genetic testing may be very useful.
There's actually one other thing that's really very interesting is the last trial that was really just recently published was PharmClo. And PharmClo not only used 2C19*2, but they also used ABCB1 for absorption because there's a 34-35 variation on that, and they also used star17, which is a hyperresponder to Plavix. And they did the totality of those 3 genetic tests with the device that's point of care and look for overall outcome. Because just like you say, that maybe there's a patient that is responsive and really could be on clopidogrel and not spend the money, but there are also people who might be hyper-responders who, being on these drugs, might make them bleed more.
So let's now move to the next presentation in the symposium that was about, complex vessel disease. So patients, those who have left main bifurcation, those who have received 4 or 5 stents, and there is issue about the duration of dual antiplatelet therapy. So when you look at the spectrum of physician practices across the world, there is a huge variability on whether they're going to keep them for 12 months, 18 months, 6 months, 36 months. So Mark Bonaca did a great presentation about that, and can you give us the highlight of that?
Well, I think the highlight is going to reflect the fact that there is such a wide variation, and I think that's because we're still not sure what to do. And I think Mark was able to give us the points of confusion that allow us to still have some variability in making a discussion. I think there are probably 3 or 4 different scales that you can use to judge whether a person's at high risk, and you can use those, but none of those really are all that terribly helpful, one more than the other. Some of the things that were really talked about are, what do you do at the end of a year? Do you take a patient and put them on a lower dose ticagrelor, which is a very reasonable thing to do for a period of time, and there's now very good data that talk about the fact that in totality they do better and have less bleeding on the lower dose, and so that was really well covered during that talk.
Yeah, so I think that what Dr. Kluck is referring to is the trial for Pegasus and patients with especially prior myocardial infarction and complex disease. And I also saw some great case presentations where there are patients with clinical situations like acute coronary syndrome. They had vomiting. The one patient had stent thrombosis. So how some of these other issues regarding vomiting that occurs in about 10 to 15% of patients with acute coronary syndrome play into the decision making of how you manage the patient clinically in the lab.
Right. Well, I think that becomes really where the rubber meets the road in these cases. Whether the patient is elderly, whether the patient is unable to absorb, whether the patient's vomited up the drug in some capacity or another, or whether you don't know that the patient's vomited up the drug or not, there are a number of different strategies that were discussed. One of them can, in fact, be platelet function testing as a possibility. One of the things that seemed like it was widely agreed upon was In that circumstance where you clearly see that a patient's vomited, where you clearly see that, there's a good chance that they have no drug on board, that a very reasonable thing to use in that circumstance is cangrelor. And in that circumstance, now you have the opportunity to buy the time that it takes to get your case done, and then once your case is done, you can make the choice of which P2Y12 site deactivation you want to really use.
Yeah. So with cangrelor, of course, you can give ticagrelor with no problem. There is no interaction. And if you want to use either prasugrel or clopidogrel, then you really should wait until the cangrelor infusion is completed.
Correct.
Before you load the patient. So, you know, what a symposium. You know, I could not believe how many people were in this symposium today. It was unbelievable. Great speakers, great talks, and unbelievable presentations of some of the latest data on antiplatelet therapy tonight at C3 2018. So thank you very much, Bryan, and have a wonderful evening.
It was a pleasure being here. Thank you.